Good morning all, and thank you Dr. Vardhaman for the opportunity. So even though the topic is actually cataract surgery in NLD obstructions, I would like to give a small glimpse about rest of the oculoplastic comorbidities also, in addition to lacrimal drainage pathways abnormalities. So basically I'll be essentially covering the NLD obstructions along with few eyelid abnormalities and ocular surface tumors. So like just a brief introduction, we have watering patients where the watering can be due to canalicular obstruction, NLD obstruction, or even with the punctal stenosis. So what are our basic concerns in cases with NLD obstruction? Is it necessary to check duct status or NLD status in all the cataract patients pre-op? Which test to perform? Which sac surgery to prefer in cases of NLD obstruction with cataract before cataract surgery? When to operate cataract after the sac surgery? What should be the duration in between two surgeries? And can we operate the eye with cataract surgery if contralateral eye has an NLD obstruction? So, like, just to address these concerns, I would like to briefly go through evaluation of the lacrimal drainage system, which is important to get the actual diagnosis and then go ahead with the decision making. So evaluation essentially will start from routine tear film height, matted lashes, and then goes to the Roplas, syringing, and rest of the investigations. So Roplas is basically regurgitation on pressure over lacrimal sac area. If Roplas is positive on pressing, if some material is coming out, that surely means that canalicular system is patent, but NLD is obstructed. So when we do syringing, these are a few important points which we need to see. These are actual steps of syringing. So first is punctum dilatation with Nettleship punctum dilator. Then which type of cannula do we use? Do we use the visco cannula or just a bent needle? Ideally not. Then is this the cannula to use? Even that is not ideal. So what is ideal is a straight cannula, because you can just stretch the canaliculus, make it straight. With the bent cannula, you are going to scrape the canalicular epithelium and going to cause more damage. So what is the proper method of sac syringing? Why do we call it as sac syringing? Because you are supposed to enter the sac and then do syringing and not do from the punctum or just canaliculus. And just like if the finding is freely patent, you can surely go ahead with cataract surgery. In cases with regurgitation, we need to know what is the percentage, what is the kind of regurgitation, and from which punctum it is coming out. So depending on the interpretation, regurgitation from opposite punctum, surely NLD block. From same punctum can be canalicular block. So if it is NLD block, yes, you should go ahead with sac surgery. If it is canalicular block, because the fluid or tears are not reaching the sac, you can safely go ahead with cataract surgery. There is no need for any surgery in spite of the watering. 100% regurgitation, again, complete block, less than 100% partial block. If the regurgitation is clear, you can still go ahead with cataract surgery. If there is no obvious mucus or purulent material, maybe you can be slightly cautious with more of an antibiotic cover. Again, similar clear fluid regurgitation. If it is NLD block, even in spite of clear fluid regurgitation, it is always wise to go ahead with sac surgery. And obviously with mucus or purulent, it is obvious that you should go ahead with sac surgery followed by cataract surgery. So these are few things which you need to remember: the type of cannula, the syringe ideally should be either 1 cc or 2 cc and not like 5 cc, 10 cc where you are just pushing the fluid. Again, why probing is important? To see if it is hard stop. Hard stop means canalicular system patent. If you are getting soft stop, it means it is a canalicular block and it is not threat for like patient even if he or she undergoes cataract surgery. So just like skipping this, in kids, if you are not sure, or if NLD is patent but the patient is having watering, FDDT can be a good test to see if there is a functional lipifora, or pediatric patient. It can confirm that NLD is blocked and you need to address it. In cases of punctal stenosis, if after dilatation NLD is patent, it's a safe case to go ahead with cataract surgery. Cases with conjunctivochalasis will cause mechanical obstruction, which will cause watering. So it is always like better to address it, because a patient may relate it to the cataract surgery. If not, like you can easily go ahead with cataract surgery, because NLD is essentially patent and the obstruction is just because of the mechanical conjunctival obstruction. In cases where discharge is there, peripunctal fullness and pouting of the punctum, it is clear-cut case of canaliculitis. You need to do canaliculotomy with curettage, uh, then treat the canaliculitis, wait at least for 4 to 6 weeks for the conjunctival sac to get rid of the microorganisms and go ahead with surgery. So summary for cataract surgery with watering: it is ideal to perform syringing in each case as pre-op workup, or at least see micro regurgitation on slit lamp. It may not be a gross or plus positive, but if you see on slit lamp, many of the cases will have regurgitation which is appreciated on the slit lamp. Ideally, medico-legally better to do syringing in most of the cases. Only canalicular block or punctal stenosis can safely go ahead with cataract surgery. NLD block, SAC surgery followed by cataract surgery. What is the duration ideal? Ideally 6 weeks, but practically you can go ahead after 4 weeks. Why this? The literature says that the conjunctival flora takes almost 3 to 4 weeks to clear after doing the SAC surgery. Otherwise, if there is urgency, you can surely go ahead with additional antibiotic preoperative coverage. Emergency cataract surgery where some phacolytic phacomorphic glaucoma is there, DCT with punctal cautery can do, but again that 3 weeks interval is still there, so be just cautious about use of antibiotics. Now a brief thing about eyelid comorbidities. In cases of blepharitis, what are the concerns before cataract surgery? The concerns are evaporative dry eyes because of the meibomitis and infection due to microorganisms. So it is always better to treat the blepharitis, wait for some while and give additional lubrication, because the evaporative dry eye sometimes takes a bit of more time to resolve even if the blepharitis has resolved. In cases of stye or hordeolum, it is basically infective condition. So, and obviously with the pain and everything, even pre-op assessment will also be very difficult. So better to wait for the stye resolution, then go ahead. However, chalazion is actually non-infective condition, chronic inflammation. It doesn't have active infection. So it's like relative contraindication. When it becomes absolute, except in like cases with large chalazia which may affect your K readings because of the astigmatism caused by the mechanical weight of the chalazion. Now, conditions like entropion, it is obvious, entropion, trichiasis, dystichiasis, it is obviously needed that you treat the condition, which is followed by cataract surgery to avoid any corneal epithelial erosions post-operatively, and which increases the chances of infection. However, in ectropion, like this patient has right eye senile plus mechanical ectropion due to chalazion, whereas left eye has senile ectropion. So in ectropion, if there is no lag of ophthalmos, you can surely go ahead with cataract surgery. It's not like entropion. But sometimes gross ectropion may cause difficulty in inserting the speculum and retention of the speculum if it is like extreme ectropion. So you need to address that before, because of the technical difficulties during the surgery. Now, just how do I play this video?
I think you'll have to go with the cursor.
It's now it's showing. Yeah, you can play both if it is. So this is basically a patient of benign essential blepharospasm, where you can actually see the spasms. Patient also has a component of apraxia of lid opening. So these cases, there is surely a technical difficulty for preoperative accurate workup, and even during the surgery also it may pose some problem. So these patients, it is better to go ahead with injection botulinum toxin, wait for 1 to 2 weeks, then go ahead with preoperative assessment. Maybe if the patient has lag of ophthalmos because of the botulinum toxin, it generally clears off within a month or so of injection. It is better that after a month you directly do the surgery, because the blepharospasm patients, the Botox effect is very short-lived. So before it recurs again, it is better to do the surgery. Then concerns about like ptosis, it can be pre-cataract surgery or it can also develop post-cataract. if it is pre-cataract, it is moderate or severe, it is always good to go ahead with ptosis surgery, which is followed by cataract for two reasons. Because the pupillary axis is clear, then only patient is going to appreciate the change in the vision. Other thing is again induced astigmatism due to the mechanical pressure of the eyelid. So if you do it later, patient may have some different K readings. It can be troublesome. Sometimes post cataract surgery, patient comes with mild ptosis, which can be surely corrected later with LPS reattachment. So basically, what are our major concerns in ptosis post cataract surgery? Most of the times, it is not mentioned in the informed consent as a post surgical complication, and these days patients are concerned about their looks. Generally, there is no photographic documentation in cataract surgery by the external photographs, because that's not a routine for all cataract patients. So it is always a subjective perception. The etiologic factors for ptosis are unknown, even though there are few hypotheses. So because of lack of knowledge about the etiology, there is a bit of no clue about how to prevent it. The theories are speculum theory and bridle suture. However, now bridle suture theory doesn't hold true, because anyways we are not using bridle suture, but still see ptosis post cataract surgery. Now, the last case scenario I would like to come to. So, this elderly lady came with bilateral defective vision and was wanting to undergo cataract surgery. But careful evaluation, evaluation actually showed a keratinized lesion, conjunctival lesion with feeder vessel. So, this was actually OSSN. So, in hurry to actually work up for the cataract cases, every time OSSN need not be limbal lesion. So it is always good to assess the overall surface. Because of these concerns, you can actually make extraocular tumor intraocular by seeding, and obviously wait for 3 months to check if it is not recurring, and then go ahead. Obviously base and margin clearance is important. So to conclude my talk, careful evaluation of ocular adnexa is very much essential before cataract surgery. Customized approach depending on the diagnosis or comorbidity is extremely important, and proper counseling of the patient is important, because sometimes the patient has come for cataract surgery but you are advising some other surgery. So these days it is very important to explain to the patient that why this needs to be done before cataract surgery, in order to avoid losing the patient to some other surgeon. Thank you so much.
Thank you so much, Dr. Aditi. I think it was a very nice and quite a protocolish presentation. Very nice.